morning. I'm Bana Al-Abrash, and today I will be presenting childhood obesity. As an introduction, childhood obesity is not just a uh, cosmetic problem or something that the child will grow out of. The childhood obesity is a serious medical condition that leads to serious medical problems. Um, Obese children tend to become obese adults, and there are many medical issues that are associated with obesity. Children now tend to take the same medication as their parents to manage their blood pressure, diabetes, and cholesterol. So, these are our objectives for today, starting with the definition of obesity. Um, we use the BMI percentile to allow us to categorize the children BMI based on where he or she falls in comparison to other boys or girls of the same age group. Unlike adults, when we say مثلا, a BMI of 25 to 30 is considered as overweight or above is considered as obese, here the children require a different standard because, as we know, their body grows so rapidly. So when I say a patient is overweight, it's defined as a BMI between the 85th and 95th percentile. Obesity is defined as a BMI above 95th percentile. And for the other categories, the underweight, they are in the less than 5th percentile, and the normal or healthy weight is between the 5th and 85th percentile. Now moving to the BMI for infants. As I said, the BMI is accepted standard measure for overweight and obesity for children up to 2 years. 2 years or older. But for infants up to 2, BMI is not assessed. Instead, the infant's weight percentile is compared to the length percentile. So for an infant whose weight for length percentile is increasing or jumping percentile, line needs close monitoring that one who is maintaining growth along the same percentile. Now moving to the epidemiology, Saudi Arabia has experienced a large increase in obesity over the last 3 decades. 6% among preschool children are obese and 9.3 in school age are obese, compared to the United States where 70% of children in the US from 2 to 20 are obese. The obesity prevalence was 13.4 among 2 to 5-year-old, 20.3 among 6 to 11 years old, and 21.2 among 12 to 19 years old. And as you can see here in the map, in North America and South America and Australia has the most prevalence of childhood overweight. For the etiology, lifestyle is the most important cause of obesity, starting with diet. For example, diet with high calorie intake that's greater than needed, or processed food, as well as food with high amount of sugars, they all contribute to obesity. Sedentary lifestyle like increased usage of computers, electronic devices, or irregular sleeping pattern, physical inactivity. Second, we have some genetic syndromes that can lead to obesity, like in Down syndrome. They will have hypothyroidism, which will and decrease metabolism, increase leptin resistance. In case of increased leptin resistance, what happens is the hypothalamic cells in the brain stop recognizing the leptin signal. Therefore, there will be no perception that enough food was ingested and reads it as a starvation, causing the brain to turn on all the hunger signals. Prader-Willi syndrome, they will present with hypotonia and feeding difficulty during infancy, which then followed by hyperphagia, leading to rapid weight gain. Therefore, the obesity in Prader-Willi syndrome is a result of chronic imbalance between the energy intake due to the hyperphagia and the decreased physical activity due to the hypotonia. And they will have also hypothyroidism and autistic behaviors. Third of all, we have some endocrine problems like hypothyroidism. They will have decrease in metabolism, decreased lipolysis, and increased adipogenesis. Cushing syndrome, growth hormone, they all lead to obesity. Lastly, we have some medication that can lead to obesity, like glucocorticoid. As we know, it increases the gluconeogenesis, decrease glucose uptake in the peripheral tissue, increase the visceral fat storage, and some hypoglycemic drugs like insulin, where it increases the glucose uptake for storage, and sulfonylurea, where it increases the insulin secretion, and some antipsychotic drugs. So moving to the pathophysiology, these are four of the most common causes. Um, Long-term positive energy, where energy intake exceeds the energy expenditure. Resistant to leptin. Leptin is a hormone that's secreted by adipocyte and it's responsible for the regulation and modulation of satiety. Hyperplasia and hypertrophy of adipose tissue, and a process of macrophage invasion favoring a pro-inflammatory and adipogenicity state. Hyperleptinemia, favoring the release of pro-inflammatory cytokines, resulting in low-grade chronic inflammatory state. So if a patient presents to your clinic with obesity or overweight, how can we approach it? Of course, by history, physical examination, and laboratory investigation. So for the history, we should start with the general history. We should start with the age of onset. When did it start and how did it start? Is it sudden or gradual? The eating habits, what do they eat? When do they eat? Activity history, birth history, medical surgical history, and medication review of system. And we should ask also about the family history, if there's any obesity in the first degree relatives, or if there's any common comorbidity that lead to obesity in the family. And we should ask also about psychosocial history like depression, school or social issues, and smoking. And that leads us to the physical examination. We start with the general appearance. We check if there's any dysformic features, because as I said, there's some syndromes that can lead to obesity. Fat distribution, skin and hair, measure blood pressure, musculoskeletal. We should check if there's any non-beating edema, flat feet, check the stature, check the genitourinary, if there's any ambiguous or underdeveloped genitalia, because in Prader-Willi or in some endocrine disorders, they might present with ambiguous genitalia. And lastly, we should check the developmental assessment to rule out any syndromes. For the laboratory investigation, we should order fasting glucose, fasting lipid panel, thyroid function test, serum leptin, adrenal function test, LH and FSH, growth hormone secretion and function test, and bone age screening. For the management, first of all, we should treat the underlying cause. And the most important management in obesity is lifestyle modification. Starting with diet, and we should give them low-calorie diet, but it's rich in nutrients. We don't want to starve the patient. We should recommend physical activity, decrease screen watching to 2 hours per day at least, emotional support, education, follow up with a dietitian. If nothing worked, we can go for bariatric surgery or in surgical management in general, but it's reserved only for cases where there's resistance in weight loss, or if there's loss of control of comorbidities after the implementation of all the lifestyle changes or the pharmacological management. But in these cases, we should monitor them for at least 2 years after surgery. For the treatment, there's non-pharmacological and pharmacological. Of course, we start with the non-pharmacological. Starting with breastfeeding, it's one of the earliest primary prevention to reduce the rate of childhood obesity. Education to the patient, to their family, healthy diet, physical activity. The recommendation says that The children must perform between 30 to 60 minutes of moderate intensity physical activity. Change in lifestyle. Then we can go for pharmacological, but it's still debated in pediatrics. We can give them metformin. It's considered as a first-line first-line drug, through its action where it decreased the hepatic glucose production and increased the peripheral sensitivity to insulin. Or we can give them orlistat, which is a lipase. It's a gastrointestinal lipase inhibitor. It prevents the absorption of fats from the diet to up to 30%. But the effectiveness of this medicine is modest because it has a lot of adverse effects that is limited here. There is a lot of comorbidities associated with obesity, starting with the endocrine. They might be pre-diabetic, which will increase the risk of developing type 2 diabetes. In females, they will have increased risk of polycystic ovary syndrome. And if they reach the puberty, they might have some menstrual irregularity. For cardiovascular, they might have hypertension or dyslipidemia. For the gastrointestinal, they might develop non-alcoholic fatty liver disease. It's the most common liver disorder in children. For pulmonary, they might develop obstructive sleep apnea. Orthopedic, they might have short stature or slept capital femoral epiphysis. It's a hip condition where it happens in teens and preteens, where the head of the femur slips off the neck of the bone in a backward direction due to the extra weight on the growth plate. And lastly, some psychological problems like anxiety, depression, low self-esteem, and social issues like bullying and stigma. Now, this is a study about sugar-containing beverages intake in toddlers and body composition up to 6 years. It studied the intake of the sugar-containing beverages and their association with the higher BMI in children. They examined the association of the sugar-containing beverages intake at 13 months with a BMI development until 6 years and body composition at age 6. The study included 2,371 Dutch children from a population-based perspective cohort study. The sugar-containing beverages intake at 13 months was assessed using a food frequency questionnaire with the validation against 24-hour recall and was standardized for total energy. BMI was calculated from a repeated weight and height measurements. The results showed that in girls, higher sugar-containing beverages intake at 13 months was significantly associated with higher BMI at age 2, 3, 4, and 6. And they observed a tendency toward the higher android and gynoid fat in girls with high intake. But in boys, there was no association with BMI or body composition, but boys with the high sugar-containing beverages intake at 13 months, they were taller at age 6. So in conclusion, the study showed that higher sugar-containing beverages intake at 13 months was associated with high BMI up to age 6 in girls, but not in boys. Can someone... And that's it for our presentation. Can someone read the question?
Yes.
Okay, I can read it.
Yeah, I can go for it.
What contributes to obesity in children? Increased sleep, decreased activity, and decreased consumption of junk food. I think it's B.
Yeah, it is. Thank you. Okay. Can someone read this one?
obesity in a child mean that A, height for weight for height is more than the 95th percentile for agent 6, BMI more than 95th percentile of agent 6, BMI between 95th and 85th and 95th percentile for agent 6, D associated with bulimia, E overeating and is the only cause. The answer is going to be B, BMI more than D. Oh, wait.
Exactly, صح.
Yeah, B, more than 95th percentile.
Thank you so much. If there's any question.
Okay, just comments. Thank you, Bana. Very good overall summary of the very difficult topic anyway. I think obesity is the contemporary disease of this actually this age group, and we're seeing more and more patients, pediatric patients with obesity or overweight, but it's more of obesity now because it's King Faisal. They don't come as overweight, they come as obesity with BMI more than 35. Why? Because we know the lifestyle now. We know that for the last 2-3 years we have been restricted to home and to online education, etc. So this is part of the problem now. Hopefully it will resolve. The second thing is dietary habits. Now it's more and more of the, we were better 10 years ago, but now we have all these delivery systems and online ordering, etc. So this is really increasing the for families who are not aware of obesity. We are seeing more and more. Really, this is a very serious issue. Third thing is that the child usually does not have insight into his problem, so it's very, very difficult. It's not like the adult. The adult, you explain to him, you tell him what is the problems with the obesity. Children do not understand. They understand, they want to eat, they want to drink, they want to play games, etc. So it's really difficult to more management. The management of obesity in children is actually more difficult to manage as compared to adults, because we have more options. The patient in adult is more receptive to your and understands his problems. What is now again the management, as Dr. Abana said, you have to increase activities, decrease intake. Do they have like options for sports centers, gymnastics, etc.? Very few people will have access to these things because we know that we don't have centers for these facilities for younger than 12 or 13. So it becomes even more difficult. Restricting food is really, again, more and more difficult. So we are in between, a hard rock and what they call stone. So what about medical management? Drugs. The Olestat usually is not used because it is really children cannot control their bowel motions. They become, at school, etc. So really, it's not used in children. Metformin is used with restrictions because it can cause liver damage. It can cause renal damage. So really, we use it in major cases where they have BMI more than 35 and they have more drugs in the market now. Is it used in children or not? Like Saxenda, Ozempic, these injection GLP analogs, GLP-1. Now they have actually, the FDA have licensed the GLP agonist to patient more than 12 years of age to be used for the treatment of obesity. So we have above the age of 12, 11, we can do either Ozempic or Saxenda. Especially Saxenda has been treated, although it's used for diabetes, but we can use it in certain doses to help obesity. The last thing is bariatric surgery. Bariatric surgery is really, I think they're done now. They're done everywhere. but it is really killing for children at this age, because especially female, they're going to get pregnant, they're going to have their own lives. We don't know what the long-term effect, but it's really being done in private centers everywhere in the kingdom, and I have seen many children in the clinic who had been doing it. طبعا there is a kind of obesity that usually will have to have this surgery, like the monogenic obesity, the genetic monogenic MC4 receptor deficiency, leptin deficiency, all these things. There is a bag of obesity that we need to do surgery for them. But overall, this is the situation now. And thank you very much, Bana, for your talk. Any questions?
Thank you, Doctor.
No, Dr. يعطيك العافية.
Okay, thank you. Thank you.